Hello, National Emergency Nursing Association Conference. Thanks, Ron and Alan, for inviting us to come and give you a little EBM nerdiness on a paper. My name's Ken Milne, and I'm a community emergency physician.
And I'm Alison Armstrong, an emergency department nurse and trauma coordinator.
So today we're going to give a quick report on nurses clearing the C-spine.
These are properly trained triage nurses using a validated Canadian C-spine rule.
I like how you really emphasize that these are properly trained and we're using a validated tool. Good job, Alison. All right, so I don't like it when you call them rules.
Oh, why, Ken?
Because they're just tempting me to break them.
Oh, well, what would you prefer?
Could you call them tools?
Oh, sure. We could call them the Canadian C-spine tools.
Yeah, just as long as you don't call me a tool. All right, so we're going to call them the Canadian C-spine tools. Well, this study was done by the legend of emergency medicine, dun dun dun, Dr. Ian Stiell.
The title is A Multi-Center Program to Implement the Canadian C-Spine Rule by Emergency Department Triage Nurses.
And it was published in the Journal of Of course nurses can clear the C-spines.
Actually, no, Ken. It was published in the Annals of Emergency Medicine in October of 2018.
So what's the clinical question we're going to try to answer then?
So the clinical question was, can emergency department triage nurses apply the Canadian C-spine rule to adult blunt trauma patients and safely clear the C-spine?
You say it with such authority, I just want to say, yes, we can.
Yes, we can.
Yes, we can.
Yes, we can.
All right, so we're going to go through the PICO. That's the population intervention, control or comparison, and outcome. What was the population in this study?
Well, these were adult trauma patients presenting to the emergency department either walking or by ambulance. They had suffered a trauma within the past 48 hours and they had posterior neck pain. They were also stable and alert. And they defined stable and alert as a Glasgow Coma scale of 15 and stable vital signs.
So they had two interventions. They had phase 1 and phase 2. We're only going to go through phase 2. Phase 1 is where they trained everybody up. So what was phase 2?
Phase 2 was the implementation phase, and this is where all triage nurses who had become certified in phase 1 were empowered by the medical directive to clear the C-spine of patients, allowing them to remove the C-spine immobilization and moving them to a lower acute area.
Trick question. What'd they compare it to?
None, no comparison. This was an observational study.
I can't even trip her up. Okay, so what was the primary outcome?
So the clinical primary outcome was the proportion of eligible trauma patients who had their C-spines cleared by the emergency department triage nurse.
And they had two primary outcomes, and that's a little sketchy. But the second one was about safety. So what was the safety outcome?
Well, the safety outcome were the number of missed clinically important C-spine injuries.
You don't want to miss those, do you?
Don't want to miss
Don't want to miss those. Okay, and there was a number of secondary outcomes. You can read the paper for that. But let's go through the key results. They got 1,400 patients into this study. Now, 500 of them arrived walking, whereas 900 of them came in by EMS. And check out this stat. 90% of those who arrived by EMS had a collar on. I was surprised it wasn't 100, sorry EMS. But 90%, maybe that's just recall bias on my part because I think everybody comes in with a collar.
Feels like it.
But 90% out of the 900 came in with a collar, and then there was 500 who walked into the emergency department. Now, fortunately, C-spine injuries were rare. They had about 1% in this cohort. What was the key result?
So, can these highly trained emergency department triage nurses remove 41% of immobilized patients' collars?
41%. All right, how about safety? Did they miss any? Was it a big number?
Well, it was a nice round number of 0.
That's right, 0 misses in this cohort. Fantastic. All right, you know that we've got to talk a little nerdy. I always have to talk nerdy. So there had to be some limitations to this type of study.
Well, because it was a comparison study, this was not a randomized control study. And so, we don't know if we would compare as triage nurses to emergency physicians. But I would suspect that triage nurses are faster at doing this assessment, and therefore the length of stay could be shorter.
I think that has some face validity. I think the triage nurses clearing the C-spine in triage are probably going to clear the C-spine quicker than me as a physician working in the back.
Oh, yes.
All right, so my nerdy point was about the external validity. I am a proud rural physician, but this study has some external validity problems because they were done in large urban centers. And even the authors identify they don't know how this would actually be impacted in a community setting or a rural setting. So I don't know. It's much more infrequent in a rural setting to be clearing the C-spines, and so we just don't have data. So we have to question the external validity.
The third point is that it's really hard to comment on the precision of the results with the event rate being so low. So while there were no missed injuries in this study, it would take only 1 or 2 misses to call into question the validity of the results.
Allison? That's enough nerdiness. Let's cut it off there. So can you give us bottom line?
Yeah, the bottom line is properly educated emergency department triage nurses can apply the Canadian C-spine rule to adult blunt trauma patients and safely clear the C-spine.
I hope everybody has a great conference.
Emergency nurses rock!
And remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.